Hi, I'm Young Jung from Gyeongsang National University. Today I'll talk about the past, current, and future cardiology in the field of antithrombotic therapy. Let's start with introduce Dr. Matthew Rowe from Duke University. Hi.
Hi.
Yeah.
Thank you very much for having me at the meeting today. It's really a pleasure to be here and to talk about a number of topics and learn all the interesting things that you're doing in Korea.
Actually, today you touched all fields related with antiplatelet and anticoagulant in the field of cardiovascular disease. So we'll talk about each component case by case.
Okay. Sure.
Okay. Yeah. Actually, I'm just start with the role of aspirin for the primary prevention. Recently published studies regarding aspirin for primary prevention. 3 large-scale randomized clinical trial. They showed just a little benefit of aspirin in the field of primary prevention. So how do you think about the next stage? Which kind of antiplatelet agent we can use for the primary prevention?
Sure. So you're describing a number of studies that were presented at the ESC, 2 large studies looking at aspirin for primary prevention, and there have been some other studies, including some meta-analyses published. I think the sum of the data are that it does not clearly appear that aspirin is beneficial in primary prevention for those patients who do not have established cardiovascular disease, perhaps those with diabetes, with risk factors and other things. And the totality of the evidence suggests that aspirin does not have a role to treat those patients. Now, as I spoke about earlier today, aspirin in the role of secondary prevention for patients who have known cardiovascular disease, that's a different story. And aspirin is a cornerstone beneficial treatment in those patients. And interestingly, we still don't know the right dose of aspirin. So we're doing a study in the United States that I'll talk about tomorrow called the Adaptable Trial, where we're comparing low-dose aspirin to high-dose aspirin in patients who have established cardiovascular disease to try to understand the best dose. So I think in some, aspirin primary prevention does not appear to be a useful treatment from the most current data, but we still need to figure out the right dose for those who actually have cardiovascular disease.
So in this point, I have a question. Just before 2000, the aspirin looks so wonderful. However, after 2000, what happened to aspirin?
I think we started to study aspirin more carefully than we did before, and we understand there are a few liabilities for aspirin. One is bleeding. It's primary gastrointestinal bleeding. And aspirin does have a risk of that, and that's shown over and over again. And that risk over time can be substantial. Mm-hmm. So aspirin does not come without risk. And I think in the studies that were done before, it was tested in higher risk populations, such as those who had an acute MI, where the benefits outweigh the risk of bleeding. But in the primary prevention population, where the risk of cardiovascular events is low, the bleeding may outweigh the benefit. So I think it depends upon the patients, and I think we started studying lower risk populations since 2000, and that's why we saw the findings that we've seen.
Actually, just my feeling like this, that just before 2000s, just starting use is just so rare, but after 2000, so many people they take the statin.
Yes.
Maybe this kind of background can influence the clinical efficacy and safety of aspirin.
Sure, I think you're right, and that is other therapies, the use of those therapies has increased over time. So the benefits of aspirin on top of statin therapy or ACE inhibitor therapy or beta blocker therapy may not be as great as it was 2 decades ago when aspirin was used in the context of much less background use of other therapies. Mm-hmm. So I think that's a very good point.
Okay. Actually, Dr. Sin also had some question in regarding to the antiplatelet therapy.
Yeah. Dr. Sin? I'm Dong Shin of Severance Hospital. First of all, I appreciate your excellent presentation before. I really liked it. You reviewed you reviewed antithrombotic and antipulmonary therapy, especially the choice and indications of the drugs. So this time I'd like to ask a question regarding the duration of dual antipulmonary therapy, especially in acute coronary syndrome. This year, we made two different reports from SMART date for acute coronary syndrome and DAPT STEMI trials, and they showed very different results. How about what do you think about the optimal duration of dual antipulmonary therapy after in acute coronary syndrome?
So as I mentioned today, dual antiplatelet therapy is aspirin with a P2Y12 inhibitor, either clopidogrel, prasugrel, or ticagrelor. And I will talk about that some tomorrow afternoon. And the guidelines recommend at least 1 year of treatment following acute coronary syndromes with dual antiplatelet therapy, whether you undergo PCI as treatment for the acute coronary syndrome or whether you do not undergo PCI. Now, studies that you mentioned, such as the DAP trial, the Pegasus trial, and others, have looked at longer durations of dual antiplatelet therapy beyond 1 year. And those studies have shown incremental benefit, but again, higher bleeding risk. Now, the patients who were in those studies were ones who had had dual antiplatelet therapy for a year and had not had another ischemic event and had not had a bleeding event. So it was a somewhat self-selected population. But within those studies, the patients who had a previous acute coronary syndrome tended to have augmented benefit. Higher risk patients, such as those with diabetes or those with concomitant peripheral arterial disease, had incremental benefit compared to the bleeding risk. And so I think, as I'll talk about tomorrow, the selection of dual antiplatelet therapy for longer term treatment beyond 1 year, there are many factors that go into that, but it's not for every patient. And at least in my practice and how I look at that is I say, for a patient who's had an acute coronary syndrome, if they've had more than one acute coronary syndrome and they've had a second one, then I would treat them for longer than a year. If they have multiple stents in place, either from before or for treatment of that event, I'll treat them longer. If they're a patient who has diabetes or also has peripheral arterial disease in addition to coronary artery disease, I would treat them longer. So those are some general factors that I use in my practice, and I'll describe that some during the talk tomorrow. But I think how long do you treat after 1 year? That's a little unknown. But what I typically do is I treat for 3 years total. And then if the patient's stable and has had no further events, I usually will stop the P2Y12 inhibitor and continue aspirin thereafter.
I think you are talking about the tailored therapy for each patient, right?
Exactly,
Yeah.
yes.
We have to choose not only the appropriate drug for the patient, but also the optimal duration for each patient. Right?
Yes.
I absolutely agree.
Well,
with
and
you.
then now there's another aspect, and I'll talk about that this afternoon. Given the results from the COMPASS trial that evaluated aspirin with low-dose rivaroxaban, a novel oral anticoagulant, compared to aspirin alone among patients with chronic coronary disease or peripheral arterial disease, that treatment regimen showed pretty dramatic benefits. Now, it's also been studied in the post-ACS setting, but on top of aspirin and clopidogrel. So the key question right now is, after 12 months, when a patient has acute coronary syndrome and they've been on dual antiplatelet therapy, should they stop the P2Y12 inhibitor and start rivaroxaban, continuing aspirin, or should they continue with the P2Y12 inhibitor? That question is unknown, and I think we should design a trial to test that, and I'll talk about that this afternoon. So I think now there's even another option that makes it a little more confusing, but does allow for even more tailored therapy than what you were just describing.
Actually, now 5 studies, randomized clinical trial, they compare the long-term depth versus potent P2Y12 inhibitor monotherapy. So these 3 published global leaders trial showed some clinical benefit, but
Sure.
did not reach the statistical significance. How do you think about this kind of monotherapy
Sure.
with the P2Y12 inhibitors just after the subacute phase?
I think it's a great question. Again, I'll talk about that some tomorrow. So the Global Leader study in 17,000 patients evaluated ticagrelor as a single agent compared to aspirin plus ticagrelor post-PCI. There was a slight reduction in ischemic events, but it didn't meet statistical superiority, and there was no difference in bleeding. So I think the answer to that question is that compared to aspirin alone, ticagrelor by itself had no increased risk of bleeding and maybe had a slightly reduced risk of ischemic events. So it may be an option to use, perhaps rather than using long-term dual antiplatelet therapy, maybe short-term dual antiplatelet therapy with just ticagrelor by itself afterwards compared to the other strategy, which is aspirin by itself. So I think there's a lot of still remaining questions to be addressed, and I think it was an interesting study. Most are saying it was a negative study, but I think in some sense it's a positive study because it tells us that maybe we don't need to be using aspirin as long, and maybe aspirin is contributing to bleeding risk more than the P2Y12 inhibitor. Because if you know that P2Y12 inhibitors by themselves, the risk of GI bleeding is less than it is with aspirin by itself.
But some doctors can criticize the discontinuation of aspirin because aspirin has some role for inflammation, some
Potentially.
the cancer prevention effect. Actually, how about the discount regimen? The low dose aspirin and just half over 2/3 of ticagrelor with PPI.
Sure.
Versus just ticagrelor only, just standard
Well,
dose.
so the PPI question is a good one. I think you're also saying that aspirin is such an established therapy for coronary artery disease that physicians, especially cardiologists, have some discomfort to stop aspirin. Now, in the COMPASS study, which again was aspirin plus rivaroxaban, they had a second randomization to proton pump inhibitor or not. Those data will be presented in 1 month at the American Heart Association meeting. However, proton pump inhibitor with aspirin and ticagrelor has not been studied. It should be, because I think that is a way to reduce the risk of GI bleeding substantially, and that may make it safer to use in that setting. So the answer to that question is just unknown, and there were previous studies looking at proton pump inhibitors, but unfortunately they were discontinued early for financial reasons, as you know. So that is an unanswered question, but I do believe that many physicians would use a long-term proton pump inhibitor. I don't commonly do that in my practice unless I know it's a patient who's had a previous GI bleed, but I think that's a potential attractive strategy.
Okay.
Yes.
Just re-
If we have another option of P2Y12 inhibitors after dual antiplatelet therapy, do you expect that P2Y12 inhibitors have some role as a primary prevention measure instead of aspirin?
Well, that's an interesting question. As I said this morning, the original study that looked at clopidogrel, Capri, evaluated clopidogrel by itself compared to aspirin by itself among patients with coronary or vascular disease. But in the primary prevention setting, that would be a very interesting question: is clopidogrel by itself safe and effective compared to aspirin by itself? And that trial has not been done yet, but it would be a very interesting one. And it might be that the bleeding risk seen with aspirin in primary prevention may be less if it's clopidogrel in primary prevention. So I think that's a very interesting suggestion, which would be a worthwhile study to consider.
You have a lot to do.
Well, I do clinical trials, as you know, spending time with us, and that's primarily what I spend my time on. So I'm always coming up with new ideas for clinical trials to keep myself in business.
But Dr. Lowe, do you believe the DISCOVER study can be done? Just primary prevention, aspirin plus clopidogrel. So we need to enroll such a kind of patients.
Yeah,
So
large.
I think that we need a lot of money, but maybe it can cannot be performed
easy.
in
Well,
current status.
Tomorrow morning, I'll talk about how we can do much larger scale studies for a much lower cost. So I think the answer to your
Most
question is we
importantly,
can do it. Come to my talk tomorrow
Yeah,
morning,
okay.
and you'll learn more about how we can do
listen
that.
to your presentation.
Okay.
Yeah. Actually, these days there is another field related with anticoagulation. So, such as NOAC. NOAC already established clinical efficacy and safety in the field of atrial fibrillation.
Sure.
Recently published COMPASS trial also shows some clinical benefit of adjunctive low dose of NOAC. Some doctors say baby rivaroxaban, BR like this.
Yeah.
So how do you think about the future study or clinical practice regarding low dose rivaroxaban, BR?
Sure. Well, I think what you describe is we're not talking about patients such as those with atrial fibrillation who already have an indication for full dose anticoagulation. That's a different population. We're talking about those with coronary vascular disease where low dose rivaroxaban together with aspirin appears to be quite effective. And I'll discuss that this afternoon. Now, it's interesting because the other NOAC, apixaban, has not been studied in the chronic disease setting. It has been studied post-ACS, and as we know, that study was harmful, so it was stopped early. So the dose matters. There is this theory that inhibiting platelets and inhibiting the coagulation cascade, maybe at a lower dose than full dose anticoagulation, has a synergistic benefit, and I'll talk about that further. But I believe the COMPASS results, I think the challenge for cardiologists and physicians in general is to say, I have a patient, they're on aspirin, they're stable, and now I want to add rivaroxaban to that. Why should I do that? And that's a tough question to address. But again, the trial that I was talking about that really needs to be done is that 12 months after ACS, continuing aspirin and then putting half the patients on a P2Y12 and half the patients on rivaroxaban would really answer that question fully. So I think we have a knowledge gap, and it's going to be hard for people to really bridge that until we get more data.
So I think to make the comparative result, so we need to think about the patient risk factor and some combination.
Sure.
So we have three combinations: aspirin, P2Y12 inhibitor, NOAC,
Sure.
aspirin. So
We could do,
So
I like that.
So
P2I12 inhibitor.
so because based on the COMPASS trial, some doctors ask me, how do you think about the benefit of clopidogrel plus and low dose rivaroxaban?
Well, it's interesting. If you look at the atrial fibrillation patient who undergoes PCI, who needs a full dose anticoagulant, the trials to date suggest that in that setting, you can drop aspirin and continue a P2Y12 inhibitor, mostly clopidogrel with a NOAC, and have pretty good results. So bridging to the patient who doesn't have atrial fibrillation, P2Y12 inhibitor with the low dose of a NOAC, maybe that's very effective, but we just never studied that. So I would love to do a trial to test that question.
I think it's a good thing to have many choices for us and for patient, but sometimes it can be very complicated situations for the patient. You have hard to choose the drugs and the duration. How do you deal with it?
Well, I think in this setting, it's really hard for a patient to know what to do. So we need, as doctors, to be informed and not be confused first, and then we need to present it to the patients. And so I look at my patients and I say, you know, you have a future risk that is something in this range, and I don't want you to have another heart attack. I don't want you to need another stent procedure. And I want you to live happy and healthily. So I say if we treat you in this fashion, I think we can reduce the risk of those events. There might be a little bit risk of bleeding, but we have to be, watching that carefully, and this is the reason why. And usually when I have those discussions, patients will say, well, I appreciate that, I'm going to follow your recommendation. But, patients trust their physicians, but their physicians, us and our colleagues, have to be well informed. And when we're unsure, we need to tell our patients, I'm unsure, but this is the best recommendation I can provide for you. And I think they appreciate that honest approach. And then we can say, but we expect new data in a year or two, and I'll reevaluate that recommendation once we have new data. So I think that's the best approach to use.
It's really, in the Korean society, we have many concern for the different profile of cardiovascular event, especially for coronary artery disease prevalence. For East Asian population, the risk of cardiovascular occurrence is somewhat lower compared to Western population. Another issue related to bleeding. So many doctors and clinical evidence, they support the more risk of bleeding. Another important field related with the response to antithrombotic agent. As you know, the clopidogrel response is so decreased in East Asian. Is related to the prevalence of KSC2018 loss of function hourly. Actually, almost 2/3 of patients they have a loss of function hourly.
Okay.
Yeah, but the outcome was not bad. Actually, worse. So in this field, everything looks good, but most large-scale clinical trial, they mostly enrolled Western population.
Exactly.
So, I just follow the concept. It's true, but the main concern is related to how to balance between efficacy and the safety of each antithrombotic agent, especially for East Asians, the Korean population. So, do you have any idea? And
Sure.
Any the ongoing trial?
Well, I think you have a strong history in Korea of doing trials on your own in Korea and doing a very good job with those studies. But in the global trials that I've worked on that are testing these new agents, we don't have adequate representation of patients from your country, from Japan, from other East Asian countries, and we need to change that. And the way we change that is by collaborating and by developing new systems so that the hospitals in Korea, for example, can enroll large numbers of patients and contribute enough to help address that question. And in addition to that, in early phase studies where we're trying to determine the dose to use of these agents, that we also enroll adequate numbers of patients so that we can decide that maybe a couple different doses need to be studied in large pivotal trials rather than just one single dose. Yeah. And I think we learn over and over again that coronary artery disease is a different disorder based on country and region that you live in. And our patients in the United States are heavier, they're younger, they have different risk factors than your patients with coronary artery disease in Korea. So it's not the same disorder, but yet we are stuck with the same drug and the same dose to try to treat our patients with, and we need better data. So I think you're exactly right, and I look forward to doing trials together with you and your colleagues in the future where it's quite different.
Sure.
We do it in a very different way, as we'll discuss tomorrow morning.
Sure. Actually, it's a kind of a registry data. The CAMIL NIH is a kind of prospective NIH-funded trial enrolling Korean MI patients.
Yes.
Just based on their result. Actually, standard dose of ticagrelor, standard dose of prasugrel did not give any clinical benefit.
Sure.
Just an increase of bleeding. Actually, in this point, the de-escalation or some reduced dose of potent p12 inhibitor treatment can be another option for high bleeding risk
Sure.
patients, such as East Asians. So how do you think about the concept of de-escalation treatment?
So I'll ask you, in Korea, say for example, for an ACS patient who undergoes PCI, is it common to treat them with ticagrelor or prasugrel for 1 month and then switch them to clopidogrel? Does that happen commonly?
Actually, it so depends on the physicians.
Okay.
Some young physicians, they most follow the guideline.
Okay.
Actually, it's not Korean guideline; it's a Western guideline. They stick to the guideline. Please keep going, even though you have a epistaxis, even though you have some gum bleeding.
Yeah.
Please stick to the guideline. But older doctor like me, so sometimes I'm somewhat how can I say, so arbitrary
Okay.
to cases. So mostly we try to find the guideline, the standard dose, but many cases, maybe more than 1/3, they switch the dose or switched with the clopidogrel.
So de-escalation does not commonly happen in the United States right now. There's a lot of talk about it, but when we've done surveys of cardiologists, we find that they're not commonly doing that. The only reason we would do that in the United States is for financial reasons, because ticagrelor is still not a generic medication, so it costs more. Recently, prasugrel became generic, and as you know, clopidogrel has been generic. So for financial reasons, we may de-escalate because the patients cannot afford the co-payment for ticagrelor, but for clinical reasons, we don't do that regularly. But I think you're right. It does depend upon how long you've been in practice, and I would say you don't look like an old physician to me. I think I look like an old physician. I think you're probably younger than I am, but I think we differ, and it'd be interesting to learn more about how you do that in your practice in your country and what your results have been.
Okay, today we covered the full field of antithrombotic agents, including aspirin, beta-12 inhibitors, and even NOAA. So we learned a lot information from Dr. Matthew, but we also know that we need to
More data.
perform a lot of study to cover the current issue.
Yes.
Okay, so another issue is some collaboration between Western and East Asian hospitals to cover some issue for East Asian paradox. So hopefully we can meet more frequently.
Yes.
Yeah.
I'm fully committed to facilitating those collaborations, and so I hope that my attendance at this meeting will be helpful in that regard, but it's my passion to do that in the future, and I commit that my organization and myself and my colleagues will work towards that goal.
Okay. Thank you.
All right. Thank you.
Thank you for your talk today.
Thank you.